So there are three major complications which surgeons encountered with the peptic ulcer diseases. The first one is perforation of the gastric ulcer or the duodenal ulcer, bleeding, and the stenosis. So one by one we discuss perforations. So as we know, since the invention of these the drugs, anti-secretory drugs, PPI, proton pump emitters, and these H2 blocker drugs, the incidence of the perforation and gastric perforation is reduced very much because patients take the medications in early phase, so the chance of recurrence are reduced very much. So as these medicines are very much responsible to reduce this case of the perforations, because gastric perforation is not a very not a very easy condition to treat. Most of the patient of the perforation have high mortality rate. Almost 50% of the cases of the perforations die. So that's it's a very good thing that now we have a very good medications, so that if we start early, then we can avoid these conditions. Nowadays, the perforation occurs not due to the peptic ulcer diseases, but this perforation occurs due to the excessive intake of the NSAIDs, because we know that NSAIDs are nowadays the over-counter drugs. So any patient can take by itself without consulting the doctor. So that's why the most of the cases of the NSAIDs perforations are due to this excessive intake of the non-steroid anti-inflammatory drugs, that painkillers. So as you know, the both the gastric ulcer and duodenal ulcers can perforate. Out of which we know that we have discussed that in duodenal ulcers, the ulcers present on the anterior wall are more tends to be perforate than the posterior walls. That's why the most common site for the ulcer perforation in the duodenal ulcer is the ulcer in the anterior walls. The clinical features present in a patient with the duodenal ulcer is the typical presentation. When the patient comes to you, usually having long time history of the taking NSAIDs, or the long time history of the patient suffering from the peptic ulcer disease, suddenly feel the pain in abdomen, and that initially pain in the upper epigastrium, and later on the pain becomes generalized, and whole abdomen is very painful and rigid, and the patient will not able to move because of the peritonitis. So initially when the perforation is occurs, the gastric contents comes in the peritoneal cavity, that irritates the peritoneum, and that peritoneums become inflamed, and that's why whenever the patient moves, that causes the severe pain. So in that cases, the patients usually lie very straight, and if the peritonitis is developed, so patient lie very straight and still, and should not patient will not move, because any sudden movement can cause the severe pain in the abdomen. So this condition called a board-like rigidity in the abdomen, that is common phenomena present after the perforations, after 3, 4, 5 hours of the perforations. Sometimes patients, this condition may appear little later, but this will present if perforation is there. You cannot avoid these conditions. So this board-like rigidity is very typical feature of the patient with the perforation of the peritonitis. And if you closely observe the patient will have the respiration that only thoracic respiration. Abdominal is not involved, because if abdomen is involved, that will cause the pain in the patient. That's why the diaphragm, the movement in the diaphragm is reduced, and the only thoracic respiration is there. No abdominal respiration is there in the patient of this peritonitis. Later on, along with the pain, the other features comes just like the fever, anorexia, In later the patient will land into the shock. Also, the feature of the shock, the tachycardia, sweating, and all these features will comes later. And if patient is not getting proper treatment, then after 24 hours, your patients may land into the severe septicemia. So generalized symptoms of the septicemia, septic shock may be there. Patients will initially bradycardia, then tachycardia, then the blood pressure also starts falling in later conditions. Later. Sometime if the actually the degree of the presentation of these symptoms is also depends on the degree of perforation. If very small perforation is there, very tiny perforation, so these symptoms comes very later. But if the perforation is big, so these symptoms can be very early. So that's why these features will be present in the patients, but not as typical in all the patients, because that presentation is depends on the degree of the perforations. And sometimes the patient's immunity conditions, immune system is also involved. So that these are the typical feature of the patient with the abdominal perforations. Usually you can diagnose the patients with the clinical history and physical examinations, but to ensure you must go through this initial condition, you must do the X-ray in the erect position. So when you take the X-ray in erect position, you see in this picture there is a gas on the diaphragm. This is typical features. Gas under the free gas under the diaphragm is the typical feature of the abdominal perforations. And along with this ESR may be raised, and the serum amylase, this is also raised, and the CT will give more accurate and more confirmatory that there is the fluid inside the abdomen. So that will give the clear cut diagnosis through CT. See, later on, due to that perforations, this peritonitis is there. The patients, the electrolyte imbalance may be there, also there. So electrolyte imbalance is also causing due to this particular conditions. So sodium and potassium electrolytes imbalance you may found in these patients. But the most early detection can be done with this erect plain X-ray abdomen that will show the gas and the diaphragm. Now comes to the treatment part. So as early as patient comes to you and you are suspecting the patient may have the perforation, then just you promptly you have to start the resuscitation. So resuscitation means you have to give the eye intravenous fluid to correct the electrolyte imbalance and to stable the condition of the patient, to circulatory system should be corrected, so patient will not land into the shock, or if mild shock is there, you can save the patient to go into the shock. And along with this IV fluid resuscitation, you must place an nasogastric tube for the gastric secretions to suck the gastric secretions, so that will not go into the peritoneum. And you must advise the patient to do not take anything from the oral. So your patient must be orally nil, and you as early as you possible you must start a broad spectrum antibiotics along with some painkiller, some to stable, to make that patient stable, to send the patient into the laboratory and for the further investigations. So first do the resuscitation with IV fluid, NG tube insertion, orally nil, and give the broad spectrum antibiotic and analgesia. These initial for 5 steps are very important. As early you give and as effective treatment you give to the patient, you can shape the life of the patients. Later on, once your patient is stable, then you plan for the surgical repair. If the incision is very, if that perforation is very tiny, then you can go the conservative management also. Few authors suggest that, but better to go for the surgical repair. If the patient's once your patient is stable, then do all the preoperative measures, and then you have to approach that perforation through midline incisions. So a large midline incision should be given, and because you can means you just only suspect that there is perforation, but to know exact site of the perforation is very difficult. So if laparoscopic facility is available, then go for the laparoscopy, so you can locate the site of the perforations. Once you locate site perforation, then repair will be very easy. Then go for that when you open the abdomen through laparotomy, you find that find the site of that perforations. You just repair, you close the defect horizontally, not in the longitudinally. You just like a pyloroplasty. So to avoid the stricture formations, to avoid that stricture in the lumen, you must suture that perforation in horizontal manners, means not transversely, not longitudinally. You have to suture that, so that increase the lumen of that particular area and avoid the stricture formation in later period. Then you may place some small portion of the omental, that called the omental patch over the repair site, so that this minimize the chance of the leakage. In case of the big duodenal ulcer is perforated, so you can do the Billroth second surgery at the same time, because later on patients may require the surgery, this surgery. So if your patient is having great means big size duodenal ulcer, then go for the Billroth second operations. After this surgery, after the surgical repair, this peritoneal cavity is washed clean with the antiseptic solutions, especially the betadines. 3 to 4 times you have to clean the cavity, so because the gastric contents was there in the abdominal cavity, so that will reduce the chance of that infection in the abdominal cavity. You have to clean that cavity, that lavage, toileting of that abdominal cavity through the betadine mixed with the normal saline, and 2 to 3 times. Then you have to close the abdomen and the suction should be placed. So then after that the surgery, you close the wound, and the patient should be kept on the PPI and eradication therapy for the long time in the long post-operative period. Close monitoring is very much essential, because most of the patient of the perforation died after 2 to 3 days of the surgery due to this electrolyte imbalance, so and the septicemia. So that's why the good post-operative care is very much essential in the patient in these type of the patients, because most of the patients land into the septic shock after 2-3 days if the treatment is not taken, or sometimes the body will not respond very much, and the patient will land into the shock and the die after 2 to 3 days of the surgery. So that's why this is very critical surgery, very difficult to perform as well as to save the patient, because this condition has high mortality rate. Okay, let me move on to the next complication, that is bleeding. So when we talk of the GI bleeding, the 60% the GI bleeding is due to these ulcers. Out of this, 6% due to esophageal ulcers, 21% to the gastric ulcer, and 33% the duodenal ulcer. You see, out of the 100%, you see the 33% is only from the duodenal ulcers. We talk about also when we discuss the duodenal ulcer that the ulcers present in the posterior walls are more chance to have the bleeding because of the presence of the gastroduodenal artery just behind this posterior wall of the duodenal. Along with these malorious tears, the erosions are having the 26%. So esophageal erosion, 13%, gastric erosion, 9%, and 4% the duodenal erosions. Erosions means when there is a longitudinal fissuring in the wall of that particular region, but there is no ulcer is there. And when there is an ulcer, then is all the four components, the margin, base, edge, all are there. But erosions are only the fissuring, no base is there, no erosion, no big wound is there. The 4% chance of the bleeding due to the malorious tears, 4% esophageal varices, 0.5% the tumor, 0.5% the vascular lesion, the Delaphoid disease, and 5% other region. So it is very important to manage the patient of the GI bleeding. So once you have the patient of the GI bleeding, you must start the resuscitation as early as possible to avoid your patient line to the shock. So the IV resuscitation is very much essential. So IV fluid, and if patient has losing so much blood, then blood transfusion may be required as early as possible. Along with this, you have to give some hemocoagulative drugs like tranexamic acids to stop the bleeding. And as early as possible, your patient is stable, then go for the GI endoscopy. So you can perform the endoscopy and you see directly the site of the bleeding. And by endoscopy, sometime you can close that bleeding also with this endoscopic suturing. So while doing endoscopy, if you found that any typical ulcer is there, any big ulcer is there, then you must take little biopsy from that so to rule out the malignancy also. So the choice of means treatment is depends on the extent of the bleeding. If the bleeding is very minimal, you can correct it with the medical only. But if there is a huge bleeding, you see that by endoscopy, if huge bleeding is there, then surgical repair may be required. So the criteria for the surgery in the patient is who not responding to the medical therapy and they are continuously losing blood. So or the ulcers which are re-bleed again and again, recurrence bleeding is there. So that persons are fit for indicated for the surgical management. Our basic aim for the surgery is to stop the bleeding. So while doing the surgery for this bleeding, endoscopy, if patient is fit and facilities available, the endoscopy is very much significant. Means endoscopy is very good, very helpful procedure with minimal with less complications. With the endoscopically you can control the bleedings, because with the endoscopy you know the exact site of that bleeding and just repair that bleeding. So while doing this surgery, always keep in mind when you take the bite, you must take the that bleeding vessels in your suture, and then you can close that suture so that that bleeding will stop. In case of the duodenum is mobilized and we have, because most likely the bleeding is in the posterior wall. So when you enter through laparoscope, you enter into that abdominal cavity, then you have to enter in the duodenum through the incision in the anterior wall. So make the incision in the longitudinally you make the incision and go through this incision inside the duodenum and close the bleeding. Take the bite, which includes that bleeding vessels, and then close the stop that bleeding, and then close that incision transversely to avoid the stricturing later. So that you have to close. Similarly, if in the bleeding in the gastric ulcer is there, then you have to enter the abdomen enter in the stomach longitudinally and then close this transversely. The principle of the management of the bleeding of the gastric ulcer is the same as the duodenal ulcer. We already discussed. And if you found that any ulcers has some unusual presentations, as I earlier say, you must take a small piece of the tissue for the biopsy to make sure that that ulcer is not malignant ulcers. Then the next complications, that is stenosis, the gastric outlet obstructions, GOO. The most common cause of the gastric outlet obstruction is the gastric cancer and the pyloric stenosis, secondary to the duodenal ulcers. The pyloric stenosis, the misnomer as the stenosis rarely occurs in the pylorus. Usually stenosis occurs in the first part of the duodenum, where the ulcers occur. But it is called, the area is same, that's why it's called the pyloric stenosis. The true stenosis occurs after the fibrosis around the pyloric channel after the healing of the ulcers. When the ulcers are in the both anterior and posterior wall, then there is a more likely to be develop the gastric obstruction, pyloric stenosis in the later when they heal. So the clinical features of this pyloric stenosis, there in benign conditions, usually the patients have long time history of the peptic ulcer diseases, and along with these, patients will have all the feature of the peptic ulcers. And then the most characteristic and the typical feature is the vomiting. And the vomiting is projectile vomiting. I mean, the effortless, forceful vomiting is there, and that is the characteristic of the gastric outlet obstruction, this projectile vomiting. And the vomitus has the character as the vomitus has no bile, because food is not passing to the pylorus, and that's why, because the bile is coming to the duodenum in the second and third part through ampulla beta, but the food is not crossing the pylorus, so that the vomitus will not contain the bile. It contains only the food taken several days before, and the food is stored there, and is vomiting. When the patient vomit, that food, that stored food will come into the vomiting. The patient will have the long time history of the loss of weight and the dehydrations. Patient looks ill, and suction splash is there. Suction splash means when you shake the patient, because the fluid is collected in the stomach, it's not going beyond the stomach, so that containing the fluid, you shake the patient. So a splash, you may hear the splash through the stethoscope. So the suction splash is also a feature of this gastric obstructions. Metabolic effect of the pyloric stenosis is causing the severe electrolyte imbalance, because whatever food is taken is not passing behind the stomach, and the renal dysfunctions, and they may be visible as acidic urine and hypokalemia that may lead to the tetanus. So these are some other associated features that may be present in these patients. Now come to the management. So the principle of the management is first correct the metabolic abnormalities, these electrolyte imbalance, and rehydrate the patient properly, make the patient stable. Then focus on the mechanical obstructions to correct that. Understand? So first, if the resuscitations, IV fluid is started, patient should be rehydrated properly. All the metabolic the whatever electrolyte imbalances there, it should be corrected first, and the gastric nasogastric intubation should be done as early as possible to do the gastric lavage, because it may contain the food stored long time before, so that food maybe get it infected and rotten there. So this gastric lavage should be performed, and the stomach should be cleaned before the any kind of the surgery. Now, if you have the endoscopic facility, then go for the endoscopy, and you can visualize the obstructions. In early mild cases, conservative management may reduce the edema and patient may be effective. Means when the obstruction is due to only the inflammation in the wall of this stomach or wall in the duodenum. So in that case, anti-inflammatory drugs should be given, and if the inflammation is reduced, usually the steroid may be used. So if the that edema is reduced, and then the obstruction may be resolved. But if the fibrosis is there due to the long time peptic ulcers healing, and there is a permanent narrowing in the lumen of the duodenum or the stomach is there, so in that cases the surgical repair may be required. So in the if the pylorus is constricted due to the fibrosis in the duodenal ulcer, then pyloroplasty is the treatment of choice. We already discussed. Just give the longitudinal incision and close it transversely. So, and if the stenosis in the stomach, contracture is formed in the stomach, then gastroenterostomy should be the treatment of choice. Gastroenterostomy means we have to resect that particular part of the stomach and do the anastomosis to the jejunum or the lower part. So these are the surgical repair should be performed in the severe case of the gastric outlet obstruction is structure in the stomach or the duodenum. If duodenum is many the extent of that structure is not very much not very severe, so in that cases the endoscopic balloon dilation may be required, but usually this balloon dilation the help only for the few times, and the condition may be recurrent also. So that's why better go for the surgical repair. So here we had discussed all the three complications: perforations, bleeding, and the gastric outlet obstruction. Then the one more topic is remaining here, the gastric cancer. Carcinoma of the stomach is also a major cause of the death. It has a very high mortality rate because early detection is the problem. Is only because the gastric cancer is not early detectable. When patient usually comes to doctor, it only moved to third or fourth stage. That's why it's very difficult to treat. But if patient comes too early, and then it is a very good, it is very much curable with the surgical operations. So this gastric carcinoma is more common in the Japan. 70 cases per 10,000 per 1 lakh patient. So this and some other geographical area of China. So carcinoma of the distal stomach is common in the lower socioeconomic status, and the carcinoma of the proximal stomach is common in the higher socioeconomic status. That's just a data fact. Etiology, that most of the conditions we already had discussed: the H. pylori infections, patient pernicious anemia, gastric polyp, patient having peptic ulcers, surgery, and smoking cigarette, dust inhalations, and diet, fried and microwave diets. These are the factors which may precipitate this cancer in the stomach, gastric cancer conditions. The clinical features in early cases, usually the patients are asymptomatic, and or the patient may have the symptom of the gastritic or the peptic ulcers. In advanced cases, the symptoms just like the early satiety, bloating, distension in abdomen, vomiting, anemia, dysphagia, epigastric fullness, involvement of the pylorus, features of the gastric outlet obstructions, that the vomiting, dehydration, all these symptoms, and the Virchow node, that enlargement of the left supraclavicular lymph nodes, that called the Virchow lymph nodes, that will come to advanced conditions, hard, painless, hard, big supraclavicular lymph nodes, and some non-metastatic effect like thrombophlebitis and venous thrombosis. So these are the clinical features which may be associated with this gastric cancer conditions. And the most common site is the proximal part of the stomach, that lesser curvature. Then come to the classifications. There is Japanese classification: type 1, type 2, type 3, type 4. Type 1 is where there is a mass, there is a overgrowth. You can see there is overgrowth. Type 2 where there is a ulcerative type, where there is a ulcers. So type 1 proliferative, type 2 ulcerative, type 3 this infiltrative and ulcerative. There is a infiltration in the walls, and there is a along with these ulcers. And type 4 is diffuse and infiltrative. So these are type 4, this Japanese classification called the Borman classifications. Type 1, type 2, type 3, type 4, proliferative, ulcerative, infiltrative and ulcerative, and the diffuse and infiltrative. Then other classification, the early and advanced. Early case include type 1, type 2, and the advanced case include the type 3 and type 4 maybe. And then TNM classifications. The TNM classifications, you know that tumor, lymph node, and the metastasis. So you know the T1 when this infiltration into the lamina propria submucosa. T2 include when the invades the muscularis layer, and T3 when this include the serosa. T4 have the T4A, T4B when this is the tumor. T4A when tumor perforates the serosa layer, and T4B when the tumor invades the adjacent organs like colon and other nearby structures. Similarly, N0 means no lymph node involved. N1 means 1 or 2 lymph nodes, a regional lymph node. N2 means 3 or 6 regional lymph nodes. N3A 7 to 15. N3B metastasis more than 15 regional lymph nodes. M0 when there is no distant metastasis, means the tumor is not metastasized in any organ. M1 when the distance metastasis is there, and the cancer is metastasized in the liver and lungs and other nearby structures. So here the staging: 1A, 1B, 2nd A, 2nd B, 3rd A, 3rd B, 3rd C, and 4th. You can see that what are the condition of the tumor, what are the condition of the lymph nodes, and what are the metastasis. So these are the different staging conditions. Why the staging is required? The staging is required to make the choice of the treatment. Before deciding the which treatment is good for that particular cancer, we must know do the staging properly. We must know which tumor is in which stage. As if we talk about a type 1 and type 2, then best treatment is the surgery, because when you know lymph node, the tumor is not invading any organ, then type 1 and type 2 is in that condition surgery is good, because you just remove that particular part of the stomach, this total gastrectomy and subtotal gastrectomy along with the radiotherapy and chemotherapy. But in type 3, type 4, surgery will not help, because tumor is already invaded to the nearby structures. So in that condition, radiotherapy and chemotherapy will help better at the palliative treatment. So in type 1 and type 2, in initial grading,